speaker, Professor Philippe Masurin. Philippe Masurin is professor of hepatology and the head of the research program on liver disease since 2001 and the chief of the Department of Hepatology and Gastroenterology of the University Hospital of Lille since 2013. He undertook a research fellowship in Professor Chukaun's lab, and he is associate editor of Journal of Hepatology since 2009. He has published more than 250 articles in prominent journals such as New England Journal, JAMA, Hepatology, and so on. His main research interests alcoholic hepatitis, hepatitis C virus, NAFLD, and hepatocellular carcinoma. Today, his topic is my algorithmic approach to management of acute severe alcoholic hepatitis, non-transplant and transplant options. So today we can get two topics. So after two topics presentation, we can get a Q&A session. So Professor Philippe Masurin, please.
Thank you. I'm trying to, I can, okay.
Sorry, I was late. Omata from Tokyo.
Okay, can you see my slide?
Yes, thank you very much.
Okay. Okay, so I have to talk about my algorithm on severe alcoholic hepatitis, and I just want to start, first of all, to tell you that alcoholic hepatitis is a serious event in the context of alcohol liver disease, and it's by definition an acute phenomenon, at least when it's a symptomatic form of the disease. And from this, there is a high risk, and we need always to consider this in the set in patients who develop alcoholic hepatitis, the risk of infection that can appear at the beginning, but also can contribute to the SIRS syndrome. And then when you have patients, particularly those who have been infected, the risk of organ failure is quite important, and the risk and leading to the death of patients. In order to identify what is the evolution of patients according to therapy, particularly when they are upon steroid, but even they are not using steroid, we developed a score that was called the Lille score. And this score was able at 7 days to identify the patient who was responder to medical therapy. In those patients had a Lille score lower than 0.45, and those patients with this low score had a high probability of being alive at 6 months as compared to those with a Lille score higher than 0.45. And when you consider this, it's clearly now accepted that those who have been considered as responders, if the patient are on steroid, you can continue the treatment, whereas in those non-responders, you can stop the treatment because they will not take benefit from the drug. And in order to have a better comprehensiveness of the response to therapy, our group use the same score and divide this score in 3 cutoffs. One is less than 0.16, and we consider those patients as complete responder, meaning that those patients have a very low risk of death at 1 month, as compared to the partial responder, meaning a Lille score between 0.16 and 0.56. And conversely, the null responder are those with a Lille score at higher than 0.56. Please note that in those patients, we strongly recommend not to continue steroid because those patients are not taking any benefit from the drug. But when you look at the disease of alcoholic hepatitis, and as usual, the things which is always a missing piece in the puzzle is the fact that we need to consider how it is the disease severity at presentation. And according to this, you will have to consider how improvement I need to decrease my risk of mortality. So let's go to, if your patient is admitted with a MED score between 45 to 40, if you want to have an improvement in survival less, meaning a risk of death less than, let's say, 20%, as you can see, you will need to have a lead score between 0.1 to between 0.30. So meaning you need to have a patient very close to have a complete response to therapy. And this is very important. And from my point of view, and now we have a paper which is on its way, we will show that probably when a patient is coming with a very severe situation, meaning a MED score higher than 0.30, then a MED score higher than 30, you will have a low probability of having response to therapy, at least if you are using steroids. So definitely those patients, if you want to bring them to a survival around 10%, a mortality around 10%, because those patients have a very high risk of death. If they are non-responders, they're going to die. And if they are responders, you need to have a very important magnitude of response to therapy in order to have a decrease of survival. For jumping from this type of mortality to have a 0.10 score of LIL, it means that the patient has to be a highly responder to therapy, which is in this case a very rare situation. This explains why most of the patients who are candidates for early liver transplantation has a very high liver dysfunction at baseline. And therefore, another way of looking at it is that, as I mentioned to you, according to a MED score, when a MED score is at 15, when you have a LID score, which is considered as a complete responder, the mortality will be 8.5%. But conversely, even a guy who is having a complete response, but the MED score is at 45, as you can see, the mortality risk is around 50%. So this explains you that you need to look at this disease as a combination of two things: my early improvement and also my disease severity. And every time you will have to adapt your strategy, you cannot consider one by one, you have to consider both of them. And this is why this combined model using MED and the LID score for me is appearing more and more an efficient way of looking at the disease severity and to stratify your strategy. So as you know, there is a long controversy surrounding the use of corticosteroid or pentoxifylline. I will say that in the European country, particularly in France, steroid was considered as a first-line therapy as compared to USA, where pentoxifylline was considered as the first one. As you know, this randomized control trial from UK was testing this treatment, and what they did show is that, first of all, prednisolone was associated with an improvement of 28-day mortality as compared to no corticosteroid. And conversely, they did show that pentoxifylline is not working. And when they look at the multivariate analysis, what was associated with an improvement in mortality in multivariate analysis was prednisolone use or not. In order to put an end of this controversy, our group, and with the collaboration of all the last randomized control trial, the 6 last randomized control trial, all the author agreed to send their individual data. This allows us to have an individual data analysis of treatment according to the group of the treatment that had been used. So first of all, we did confirm that steroid was associated with an improvement in survival at short term and at 28 days as an endpoint, which was always the primary endpoint in most of the study. And as you can see, nothing is magic. The steroid was associated with a percentage of response according to the LIL score, meaning a LIL score lower than 0.45. This percentage of response was higher in the patient randomized in the corticosteroid group as compared to the patient randomized in the control group. And when you compare corticosteroid to pentoxifylline, this individual meta-analysis allows us to have those several comparisons. As you can see, corticosteroid has higher survival benefit, corticosteroid patient as compared to non-corticosteroid patient, and the percentage of response was also higher, meaning that, as I mentioned, nothing is magic. in order to improve survival using any drug in this setting, you need to have an improvement in liver function and at early time, because as I mentioned, those patients, more they are severe, more you will have to have a very high early response and an important magnitude of response in order to improve survival. And when you compare the pentoxifilin as a treatment to no pentoxifilin, as you can see, this drug was not associated with any survival benefit at short term. And this was explained by the fact that liver disease was not improved, liver injury was not improved in patients treated with pentoxifilin as compared to the others. As you can see, the percentage of response to therapy according to the score was similar. So one thing, as I mentioned, is important in this disease is the infection. And you need, first of all, to differentiate two things. The infection, which is present in around one-fourth of the patient, 25% of patients, when they are coming with alcoholic hepatitis, the severe form, they are already infected. So meaning that it's mandatory to have an extensive screening of infection in those patients when they are admitted to the hospital. But in addition to that, you need to consider that those patients are still at risk of development of infection when they are treated with steroid. But even you are not using steroid, your risk of infection after admission is quite high. And one thing which was important that we did show is that there is a kind of global consensus in some centers, in some countries, that when a patient was infected, the steroid is now contraindicated, which was not the case, and this has been confirmed by several studies after this one. What we did show is that when you have a patient who have an infection that has been controlled by efficient antibiotic, you can use steroid, and those patients infected before initiation but treated had the same outcomes than those who were not infected before starting steroid. So definitely the fact that there is an infection at admission, the only contraindication to the use of steroid is the fact that you are not able to control the infection. If you are able, you can start steroid. And when you compare this to the infection, the median time, which was another issue, is that when you look at infection after you start therapy, so as you can see, this was associated with a drastic impact. It was an important prognostic factor, meaning that the patient who are developing infection after the start of steroid, as you can see, the survival is quite low as compared to those who are not developing infection after starting steroid. And this has been explained by two things. One of all is the fact that steroid is a drug associated with the increased risk of infection. This has been shown by an individual data analysis of the study of the randomized control study from the STOPA group. And as you can see, they did show that when you compare steroid as compared to placebo, your risk of infection is quite high in those patients randomized to steroid as compared to the other one. This is a clear-cut demonstration that by definition, steroid was associated with an increased risk. And this, as I mentioned, is very important that the same group, the group from England, so different study from the studies that we published, did confirm that baseline infections is not associated with risk with increased risk of infection. But what we need to consider every time is that you can explain everything if you are considering also another important thing is the improvement rate of your patient. And as I mentioned again, the magnitude. And as you can see, a patient who is a non-responder had a higher risk of infection as compared to a responder treatment. So it means that when a patient is a non-responder, you need to focus particularly on the risk of infection because half of them will develop infection. So one thing, but I will skip a little bit on this one, is the fact that maybe the use of bDNA may be interesting to predict who will develop an infection upon steroid. And as you can see, when you have a high bacterial DNA before starting steroid, it seems that the outcome is worse when you are using steroid. This may, if it's confirmed by other group, that the use of bacterial DNA can also help you out to define who will be treated or not by steroid. But as I mentioned, this study has not been confirmed so far by another. And I think the group is working on this issue. And if they are confirming that this data, this will be quite important. But now we need to know how type of test we can use of assay we can use to evaluate the bacterial DNA. So one thing also I want to stress, and I think the lecture that will come just after mine from Dr. Leggio is important, is that you need to consider as a physician, what are you looking for? So, and you need to combine in your head, what will be my drivers of mortality at short term and long term. In order to identify this, and this is very important for the development of drug, but also to the comprehensiveness of the management of patients after the development of severe alcoholic hepatitis. So we did look at short-term events in this study and a long-term event. So it's a prospective study from our center. And what we did show is that, I will make it a short story. When you are looking at severe alcoholic hepatitis, the main driver of short-term mortality during the 6 months following the onset of the disease, it's the disease severity at baseline, the response to therapy. And this explains that why now the health agency from FDA and EMA accept 3 months outcome as the only outcome for testing a drug. Because after this, the main driver of disease mortality will be the recurrence to alcoholism behavior. So it means that you need at least to look at your patient. So if your patient is alive, you need to consider whether it was a response to therapy. And if this patient was a responder to therapy and was not drinking anymore after the first episode of alcoholic hepatitis, the risk of death is minimal, 5 to 10%. If your patient is not drinking, but was not a responder to therapy, there is a substantial risk of death at 5 years, which is around 40 to 50%. It means that when a patient is a non-responder, you need to carefully look at this patient, particularly to his liver function according to the MELD score, and probably put this patient on the list of liver transplantation if the MELD score is deteriorating over the time. Because as I mentioned, even though your patient is not drinking anymore, but was not a responder at the first episode, this patient will have a substantial risk of death, regardless of whether he will drink or not. But conversely, if your patient has an alcohol relapse, you will have a high risk of death, no matter whether the patient was a responder or not. Please note that, however, when you are looking at the impact of alcohol relapse on long term, when a patient is a responder, he will have 50% of dying within 5 months after. So meaning a responder who is relapsing in alcohol, as I said, will multiply by 10 his risk of death from 5% to 50%. And if the guy is a non-responder who is relapsing in alcohol, the risk of death is around 90%. So this explains us that when we will look at long-term mortality in this disease, definitely we will need the help of our addiction specialists in order to improve the outcome at long term. So 6 months or 3 month period is an optimal period for testing drug-preventing liver injury, because as I mentioned, the liver injury is the main driver of the outcome. But when we are after 3 or 6 months, and I think as a conservative point, I will say 3 months, definitely we need to avoid study testing preventing the liver injury, at least because those patients, the risk of death will be related to the alcohol relapse. So in order to simplify my algorithm, this was proposed in a review that we recently published. So this is, as I mentioned, when a patient is presented with alcohol-associated liver disease and jaundice, you need to perform a comprehensive workup of infection. So as I mentioned, everything has to be done. As you treat blood culture, regardless of the temperature, urine analysis, checks X-ray. You need to perform hepatocellular carcinoma. You need to exclude the over-precipitant of decompensation, including drug-induced liver injury. And then in a second step, you need to assess the severity. If the score is higher than the MELD score is higher than 20, and the NIL score is the Madrid function is higher than 32, therefore you will use steroid, and according to the response to therapy, you will stop steroid if the patient is a non-responder, particularly if it's a null responder and it's eligible for liver transplantation, you need to consider liver transplantation. I will talk on this later on. And if the patient is a clinical alcoholic hepatitis without the criteria of disease severity, material function and MED, definitely you need to go to randomized trial because we don't know up to now what is the optimal treatment for those patients. So the near future, combinative therapy, as I mentioned, pentosufin is not working alone or in addition to steroid. We did show that a long time. So now we just finished a study, a randomized controlled trial, testing the combination of amoxicillin and clavulanate and prednisolone as compared to prednisolone alone. This is a French randomized controlled trial. I will make it a short story because it's a negative one. So those patients were treated randomized in 2 groups. And short story, nothing in terms of primary endpoint, in terms of risk of survival. As you can see, the survival was not modified by the use of amoxicillin and aceclidine. So definitely, this is the end of this story, at least in our center. So I will just mention there is 2 drugs that are coming, and I am very interesting in the result for this randomized controlled that will come. So one is the Direct 9028. This drug was tested and presented in a study in ASLD 2 years ago. Now there is a phase 2 that is starting. So I will make it a short story. So they made a study with testing different dose and also in a different cohort according to disease severity. Very well done study. And this study was interesting for one thing, which is very important, because when you consider the response to therapy assessed by the Lille score, as you can see, they did observe a response to therapy around 80 to 90% according to disease severity. This is a very high score because I can tell you that in the steroid, as I mentioned before, the response to therapy is around 60%. So this drug is a very interesting one. And there is another one, which is IL-22. This also will go to a phase 2, phase 3 study. And this study is testing the liver regeneration, which is an important process in this disease. So let's go to one thing I want to address. It's very important, is the fact that ACLF and alcoholic hepatitis. It's a problem for me of concept. First, ACLF is every time you need to ask yourself, why my patient is dying? Why is the main outcome? So I would make this a first a short story. There is a risk of infection, which is associated with the development of ACLF and admission of MED. As I mentioned, disease severity at baseline is always important. And this is associated with the risk of acute and chronic. And when you look at what is associated with the survival, is the fact that you are developing an event of a decompensated multi-organ failure or one organ failure, whatever it is, and the fact that you are severe. So I would say to you that which is important for me is not the concept of ACLF. It's a concept of when I want to have to go to avoid the risk of a crash test, speed is disease severity. This is the ACLF 2 and 3, it's a crash test. It means that for me, those patients are candidates for liver transplantation, not candidates for any drug anymore, because they will have a high risk of death. We will have nothing will change their outcome, and their driver ability, response to therapy is a way to improve survival. So we need to have drug before the development of ACLF 2 and 3. ACLF 2 and 3, when it's developed for me, is just a question of early liver transplantation. So I will go now to what is the issue of early alcoholic hepatitis. Just to remind you that alcoholic hepatitis was considered as, alcoholic disease was considered as an indication of liver transplantation in 1983. And was endorsed by a French conference consensus in 1993, and is a consensus French conference consensus was a very important step forward in this, because this French conference consensus did state that we need a pilot study in the non-responder to alcoholic hepatitis to determine whether or not early liver transplantation may change outcome and whether or not this may be considered as a potential option for the treatment of those patients. And this French conference consensus did state wait and watch strategy using the 6-month criteria is unfair for the non-responder with 70 to 80% probability of dying, and they recommend pilot study evaluating early liver transplantation in non-responder. And this was a very important, because without this strong statement, the French group and the Belgian group will never have been allowed to test this in a pilot study that did show clearly that the survival was drastically modified in the patients who were early liver transplant as compared to those who are not transplanted. And since that, the United States experience has been published. They use the same approach of disease severity as compared to the French. The only difference in the French liver biopsy was performed in most of the patients who are candidates. And the clinical characteristic was the same as those published by the French Center. As I mentioned, those patients who are non-responder, you see the least score is 0.9. The MELD score at listing was around 37, which is a high MELD score. So definitely sick patient. And I will make it a short answer. It's working, and with a 90% of survival, which is drastically higher than that has been observed in non-transplanted. And that the second point is, what is the sustained alcohol use after liver transplantation? And after 3 years, there was around 20% in those patients. So in order to determine also 2 or 3 questions, we look at the long term. What is the long term of those patients who have been candidate for early liver transplantation? And then the long term is around 60% at 5 years and 50% at 10 years, which is close to that has been observed in the setting of alcohol liver transplantation, regardless of, I would say, using the 6 months, we are around 60 to 50%. So same long-term outcome. Please note that most of the outcome after the performing the liver transplantation was, as usual, cancer and infection after liver transplantation. And the survival of the 2 cohorts, the cohort that has been used in the setting of the randomized control, in the setting of the New England paper, we compare this to the patients who were transplanted after this period. And as you can see, the outcome was similar, meaning that definitely the survival was close to that has been observed. Now, in terms of alcohol use, which is very important, this study shows that at least at 12 months, and there are around 12% of heavy alcohol use and 12% of non-binging. So relapse of alcohol was quite, not I would say high, but significant. So now I will go to the study that we did publish in the Lancet Gastroenterology. In this Lancet study, we compared 3 groups: 1 transplanted, early transplanted. 2, group B was a patient candidate for transplantation for alcohol-related liver disease using the 6-month abstinence as a criterion. And the last group was a patient who were presented with severe alcoholic hepatitis, not responding to medical therapy, denied for early liver transplantation. So primary outcome was relapse in alcohol. So the primary objective was, it was a non-inferiority study, and the secondary outcome was profile of alcohol relapse. Disease was as the following. Patient was, the control group was a patient candidate for liver transplantation using the 6-month criteria. The patients were treated with medical therapy with alcoholic hepatitis was selected according to an algorithm score higher than 220 as compared to an algorithm score lower than 220. Those patients were not selected, and those patients with the higher score were selected. So I will skip this because I need to keep on time. And I will go to the result. The result is that the primary endpoint, there is no difference the non-inferiority was not, margin was not obtained, so we cannot conclude on non-inferiority. However, we did observe a probability of relapse, which was 30% in the group, 33% in the group treated with early liver transplantation, as compared to 25% in the patient transplanted using the 6-month criteria. But the time spent on alcohol was, with alcohol consumption was the same. The rate of heavy alcohol consumption was higher in the patient early liver transplantation. And this is important things to consider in the future. In terms of survival was similar, using even though those patients were more sick than the other group. And compared to the non-response, as you can see, if you consider as a strategy, and you consider not a per protocol, but the intention to treat analysis, you can see that when you put a patient on a waiting list, you will have a 70% probability of dying as compared to the patient who are not eligible. Drastic different outcome, because we consider at that time even the patients who were dying before liver transplantation and those who are dying after. So meaning that some patients, there is a substantial number of patients who are dying before getting the liver transplantation because they are very sick. So specific conclusion is that rate of relapse is around 40% as compared to 25% when you consider the 6-month criterion. Heavy drinking is more frequent, and early liver transplantation is clearly associated with a major improvement of survival. So in order to finish, one or two things, the modeling, there is a study performed by the American Center, which is very important. They look at life expectancy using a modeling approach, and they did show that life expectancy is quite high using your liver transplantation. You have a gain of life expectancy, which is around 65, drastically higher than when you delay your decision to transplant. And then I would just want to tell you that we need to now to homogenize our rules according to transplantation. In France now, 94% of centers are using the liver transplantation, whereas in Canada, this is still considered as a contraindication for access to therapy. And when you look at the United States, it's becoming more and more centers are now performing liver transplantation, and more procedure has been performed according to in those patients with alcoholic hepatitis. So now I will finish and conclude that corticosteroid improve 1 month survival mortality, but this is not the best option for the future. We need to find out new drug because this molecule is able to improve only 1 month, and the benefit seems to disappear over the time. Controversy surrounding the effect of this treatment did illustrate the fact that now experts need to focus on how to guide therapeutic development after taking into account all the scientific data. Future therapeutic development will need to integrate the mechanism of death, early death versus late death, and early liver transplantation is becoming a procedure for routine practice in highly selected patients, because I want to insist on the fact that as in French, we are using an algorithm to select patients, meaning those patients have been drastically selected, even though we have a high risk of alcohol relapse, as I mentioned before. And thank you very much for your attention.
Yeah, so Philip, Nasrin, thank you for informative presentation. As I mentioned, we can get a Q&A time after second presentation. So Professor Omata will be introduced the second speaker. Professor Omata, please.
Yes, thank you very much, Dr. Yang. The second speaker today is Dr. Lorenzo Reggio. He is currently a senior investigator in the NIH Intramural Research Program with faculty appointment both at NIDA and NIAA. Dr. Reggio's clinical research has been primarily focused on the treatment of alcohol and substance use disorders with a special emphasis on the role of microbiome, gut, liver, brain, and neuroendocrine pathways, as well as the GABAergic pathways, and on the medical consequences of alcoholic use disorders, focusing on alcohol-associated liver diseases. And today, he will talk on the topic, the preventing and predicting the relapse in patients with severe alcoholic hepatitis undergoing liver transplantations. Dr. Lorenzo Reggio, please.
Thank you. Okay, I'm trying to share my screen. Okay, do you see my slide?
Yes.
And do you see,
Yes.
just the one? Just the one?
Yes, one.
Okay, perfect. Okay, so thanks so much for having me today and for your invitation. And I look forward to the discussion as well. Oh, sorry. Okay, no way. Okay, and you still see one slide?
Yes.
Okay,
Actually,
perfect.
maybe 1.5.
Okay, how about now?
Yes, perfect.
Okay,
100%.
perfect. Yeah, okay, perfect. Okay, so as you all know here, when we think about alcohol use disorder in the context of a hepatology in particular, we really focus a lot on the total alcohol abstinence, because we know that the total alcohol abstinence is the cornerstone in the treatment of alcohol-associated liver disease, ALD. So I'm starting by kind of giving a broad introduction about how we even assess alcohol use disorder. How do we know that the patient has an alcohol problem, such as alcohol use disorder? So one actually of the main and widely used scales and questionnaires worldwide is actually the alcohol use disorders identification test, audit. That's a widely used screening tool effective in identifying excessive drinking. It was developed by the WHO, so the World Health Organization, and it's very brief. It's actually 10 questions. And the audit is becoming more and more widely used in clinical practice as well as in the clinical research. As a matter of fact, for example, in the United States, at the Veteran Affairs hospitals, every single patient, not just in addiction medicine or hepatology, but every single patient that goes to the VA, even if they go, let's say, to surgery, they will have an audit to assess unhealthy alcohol use. Now, the audit is brief, it's only 10 questions, so it's actually quite good to be used in primary care. If you want to go deeper in quantifying how much a patient drinks in terms of alcohol consumption, another assessment, another tool is the timeline followback. The timeline followback allows to standardize how much people drink based on the standard drinking unit. The trick is that the standard drink unit may in fact be different, for example, in Asia versus Europe versus United States. And so this is actually exactly why the standard drinking unit should allow to quantify alcohol consumption regardless of the type of alcohol that the person is drinking. It is a time consuming, it does require some training. And so the timeline followback TLFB is quite used in a research setting, for example, in the context of clinical trials, but less used in the clinical practice. And then, of course, if we think from a medical standpoint about diagnosis, we have two main ways how we can make a diagnosis of what we used to call alcohol dependence with the DSM-4, and now we call alcohol use disorder with DSM-5. And even if here I'm showing the DSM, which is the US system for diagnosis based on the American Psychiatric Association, the ICD-11, which is more international, does use a similar categorization. And here what we have is actually 11 criteria, and this 11 criteria help clinicians to make a diagnosis of alcohol use disorder. And based on the number of criteria, we define alcohol use disorder as a mild, moderate, and severe. The DSM-5 is actually, as you know, the most recent diagnostic manual and guide to make a formal addiction and psychiatric diagnosis of a patient with alcohol use disorder. And I want to point out that compared to the DSM-4, there have been a few important changes. One is we merged alcohol dependence and alcohol abuse under one umbrella, which is alcohol use disorder. And in fact, we don't use the word abuse any longer, also because of the potentially stigmatizing meaning. And also, we added craving as one of the criterion, which didn't exist before formally in the DSM criteria. And finally, we dropped the legal consequence of alcohol use disorder as a criterion. This was before present in the alcohol abuse diagnosis. We don't use the legal any longer, again, because of the potential stigmatization of the consequence of a criminalization due to alcohol use disorder. So once we have a diagnosis, of alcohol use disorder, of course, our goal is to provide the treatment to these patients, right? And so far, I'm talking about patients with alcohol use disorder in general, not necessarily patients with alcohol use disorder and alcohol-associated liver disease. And so when we want to provide the treatment, we have a behavior treatment, which can be one-on-one family or group sessions, or we can provide the pharmacological treatments. And starting with the behavior treatments, the three most commonly used for which there is a robust evidence of efficacy are the cognitive behavior therapy, CBT, that provides the highest in the literature, the highest level of empirical support to treat AUD with the durable effects, although limited diffusion in clinical practice because of the complexity and the training required to become a CBT provider. Contingency management, CM, is also one of the highest levels of empirical support. CM has demonstrated efficacy in AUD and evidence indicating periods of sustained abstinence. Finally, the motivation interviewing, MI, also has demonstrated efficacy in AUD, facilitate counseling efforts, and also practitioner training directly influence motivation interviewing effects. The mechanism of how these three behavior approaches work are quite different. With the CBT, you're working on the more cognitive structure of the patient to improve a patient's cognition and awareness of their alcohol problems. With the contingency management, you are providing a monetary reward each time a participant will provide, for example, a negative breathalyzer or a negative biomarker of alcohol consumption, which is not different to what we do sometimes to motivate people, for example, to get the COVID vaccine during the pandemic, where you provide a monetary reward. And finally, with the motivation interviewing, you work on the overall motivation of the patient to engage in treatment and buying in with the provider the need and importance of maintaining alcohol abstinence. Now, these behavior treatments, unfortunately, are not widely used in clinical practice. And in part is because, and I will talk more about the barriers and challenges to implement the treatments in alcohol disorder, but one of the challenges is time, and is the availability of psychologists and counselors with the right training. And in fact, when we look at the liver field, their use is even less, because again, the challenge in a healthcare setting in a hospital to have wide access to these treatments and to these providers. Nonetheless, I'm mentioning here this review, a systematic review by Anam Khan and colleagues, where actually they systematically reviewed the use of psychosocial interventions in patients with alcohol use disorder and chronic liver disease. And they show that while there is not robust evidence for behavior intervention alone to maintain abstinence, on the other side, the integration of medical care with either CBT or MI shows a significant effects in inducing and maintaining abstinence. And here, I think the key word, which I will talk more, is the word integration. But the bottom line, the take-home message from this review is that if you provide a behavior treatment to patients with AUD and ALD, that actually behavior treatment is likely to work, in particular, if that behavior treatment, such as CBT or MI, is integrated with medical care. Now, in addition to behavior treatments, we have now a better understanding of the neurobiology of alcohol use disorder. We are now better positioned, thanks to progress in neuroscience, to understand why some people develop addiction, which is, if you will, the more severe form of alcohol use disorder. And we have used this information from neuroscience to identify new targets and develop new treatments for patients with AUD. We have, in fact, the treatments approved to treat the patients with alcohol use disorder. And these treatments include acamprosate, disulfiram, and naltrexone. And when we try to apply these pharmacological treatments in the context of a liver disease, again, we have some challenges. For example, disulfiram should not actually be used because of the potential risk of a hepatotoxicity. Naltrexone also has a potential risk of a hepatotoxicity, although over time, in the last decades, we have learned that the risk of a hepatotoxicity with naltrexone is much lower compared to what we originally thought. And it's even lower when we use the sustained release formulation naltrexone, which is a once-a-month formulation, because actually that formulation will bypass the first-pass metabolism. And finally, acamprosate has no known contraindications for patients with ALD. And even if there is only one formal study that was done in France in the 90s, testing acamprosate in patients with liver cirrhosis with Child-Pugh A and B, there are no really clinical pharmacological reasons why acamprosate should not be used in patients with ALD. And finally, in Europe and also in other countries, nalmefene was recently approved. Nalmefene has a pharmacological mechanism of action similar but not identical to naltrexone, and there is no known risk of a hepatotoxicity with nalmefene, although nalmefene has not been formally tested. Anyway, even if we do have some medications that we may use for patients with AUD and specifically for patients with AUD and ALD, these medications do not work for everybody, but also they're not widely used, prescribed in clinical practice for reasons that I will explain more soon. So that really means that we need to develop new additional treatments to help our patients with AUD. In fact, in the last decades, efforts have been made to develop new treatments and repurpose medications already used in clinical practice in the context of AUD. And those medications include baclofen, gabapentin, ondansetron, topiramate, varenicline, and there are more actually in the pipeline, in the horizon. And I will mention a few of them now, just to give you some highlights of the most recent medication development efforts in the addiction field. Baclofen is, in the context of AUD and liver cirrhosis, maybe the most interesting story, because in fact, in this early study that I was part of with Giovanna Dolorato, we showed in a randomized clinical trial that the baclofen was effective in promoting abstinence, specifically in patients with alcohol use disorder and liver cirrhosis, ranging from Child-Pugh A to Child-Pugh B and Child-Pugh C. And we also found in a secondary analysis that even if the sample was smaller, again, the baclofen was effective in maintaining alcohol abstinence in patients with alcohol use disorder, liver cirrhosis, and the hepatitis C virus. This was a study done before the implementation of the new effective treatments for HCV. Now, whether baclofen works or not for all patients is still a source of controversy, but for example, specifically to the use of a baclofen in patients with AUD and ALD, there was a follow-up study done in the US at the VA that did not replicate our findings, while another study done in Sydney did replicate our findings. And if we put these two studies together, and together with our first randomized clinical trial published in 2007 in The Lancet, our overall conclusion is that the baclofen may in fact help some patients with alcohol use disorder and liver disease, but only those patients with a higher level of severity. In fact, our population, as well as the Australian population, had a higher severity of alcohol use disorder compared, for example, to this population at the VA in the United States. And as a matter of fact, based on this work on the baclofen, both of the ACG and AASLD have included the baclofen as a potential pharmacological tool that the practitioners could use as a way to help patients with ALD and AUD to reduce alcohol drinking and to promote alcohol abstinence. And recently, we actually met as a group of people with expertise in the use of baclofen in patients with AUD, and we developed a consensus statement where we overall show and conclude that in fact the data with baclofen are conflicting, primarily and chiefly because of the heterogeneity of patients' response, but its use is potentially important in specific settings, such as in hepatology. But I'm using baclofen only as a mere example of a pharmacological tool that we could use to bridge the alcohol addiction field and the hepatology field by using a pharmacological tool such as baclofen that could be used in a multidisciplinary integrated care with both addiction doctors and hepatologists. But baclofen, again, is only an example. There are more medications that could and should be used to help to fill the gap between the addiction arena and the hepatology arena. And for example, I mentioned before acamprosate, and again, there are no reasons why acamprosate could not be used in the liver setting. But in addition to acamprosate, which is approved for alcohol disorder, in addition to baclofen, other two examples I want to mention today are gabapentin and varenicline. And the reason is, again, because from a pharmacological standpoint, gabapentin and varenicline do not have hepatic metabolism, or they have a minimal hepatic metabolism. They have not been associated, they've not been associated with hepatotoxicity. And so there are no really clinical or pharmacological or safety reasons why gabapentin or varenicline could not be used in patients with AUD and ALD. And speak about AUD at large, not specific to patients with liver disease, a variety, in fact, of clinical studies have shown that the varenicline may reduce alcohol drinking craving. And also a multi-site clinical trial showed that the varenicline is effective in reducing heavy drinking. And in particular, the effects of varenicline were more pronounced in those patients who also reduce smoking. That's not surprising because varenicline is approved for smoking cessation. This data also suggests that varenicline may be helpful to reduce alcohol drinking. So it is actually conceivable that the patients who are both alcohol dependent and smokers may better benefit of a varenicline. And this is also in line with the overall idea that the medications do not work for every single patient with AUD. So we really need to make stronger and stronger efforts to move toward personalized medicine. So we need to identify which patients responded to which medication. The other example is gabapentin, for which, again, we have data from human lab studies indicating that the gabapentin reduces the cue-induced craving. Also, we had a randomized clinical trial by Barbara Mason and colleagues showing that the gabapentin dose-dependently reduces drinking and the relapse-related symptoms such as craving, insomnia, and dysphoria. And more recently, a randomized clinical trial, which I was part of, did not actually replicate those findings. And one concern with this large randomized clinical trial is that actually the population enrolled was a population with lower severity of dependence. And in fact, recently, Ray Anthony colleagues in Charleston, they show that gabapentin was effective, but only in those patients with history of alcohol withdrawal and with more alcohol withdrawal symptoms. And using machine learning, Laska and colleagues reanalyzed the data from the multi-site randomized clinical trial from Falk et al. And they show again that there is a subgroup of patients who, even in the negative clinical trial, responded to gabapentin. So overall, again, suggesting that just like naltrexone, acamprosate, baclofen, varenicline, disulfiram, gabapentin too does not work for everybody, but only for some patients with alcohol use disorder. And I also want to mention that the gabapentin, as well as the topiramate, even if I didn't have time today to talk about topiramate, but both of these medications, gabapentin and topiramate, have been endorsed by the American Psychiatric Association. They are not approved for alcohol use disorder, but they have been endorsed by the APA, in particular for patients with moderate to severe alcohol use disorder who have a goal of reducing alcohol consumption or achieving abstinence, prefer topiramate to gabapentin, or they are intolerant to the other medications such as naltrexone or acamprosate, or they have not responded to naltrexone or acamprosate, or they have contraindications to use either naltrexone or acamprosate. I also want to point out how important it is to think about addiction medicine treatment for patients with ALD, no matter what is the stage and the severity of the liver disease. In fact, AUD treatment should be considered for all patients with liver disease. In fact, addiction specialists should be a function of an integral part of the treatment team, both before and after transplant, so at any stage of the liver disease. In fact, the integration of addiction and medicine, so addiction and hepatology, is actually critical and becomes more and more critical now that we have effective treatments to treat hepatitis C, HCV. And I will provide a few preliminary, but we believe quite important examples of how integrating addiction and hepatology with a multidisciplinary team pays off. And it does pay off both in terms of people's life, helping patients, but also in terms of overall public health. For example, in the study that I was part of with Giovanna Dolorato, here we showed that by building an alcohol addiction unit within a department of internal medicine and hepatology led to robust improvement in outcomes. Specifically, when we compared the outcomes of a liver transplant before and after the creation of this alcohol addiction unit, we saw that after liver transplant, the percent of patients who had the recurrence of alcohol use disorder was much lower when we started the alcohol addiction unit within internal medicine compared to before. And similarly, we saw using Kaplan-Meier that the proportion of survivals were actually higher when actually after we implemented the alcohol addiction unit compared to before implementing the alcohol addiction unit. So in other words, people lived for longer and less people died. Similar data have now been generated, for example, by another group in Italy, as well as by another group in France. And overall, this data also in the context of liver transplantation going to the same direction, showing that the integration of an alcohol addiction group within a liver transplant multidisciplinary team leads to better outcomes for our patients. And of course, we know from Professor Maturin, who just gave a presentation, that this has been also been instrumental in the early liver transplantation for severe alcoholic hepatitis, which is in fact the pioneering work that Philippe and other colleagues in France and Belgium have pioneered in the last decade. And even beyond the liver transplantation, but and I say beyond because what happens is in the field, the liver transplantation is actually a great model of a multidisciplinary team where we are able, and has been more feasible, to put everybody together. But where we have the challenge is actually early on when patients have a liver problem, but they have not developed a severe liver problem up to the point of needing a liver transplant. It's at that early stage that actually we struggle where we don't have a multidisciplinary approach. And for example, here in the United States, in Michigan, Jessica Mellinger, together with Scott Winder and Anna Fernandez, have pioneered a multidisciplinary clinic where hepatology, psychiatry, psychology, social worker, they work together, and every single patient is seen by each single specialist in the same day, back to back. And here, this model is very important because this model does not focus only on liver transplant, but really focus on providing this integral care early on. So when patients have, for example, ALD, but they have not developed a cirrhosis, they're not actually in need for liver transplant yet. So that's important because at the end of the day, our goal is to prevent that the people develop the most severe forms of ALD. But the example here in Michigan, there are more examples both in Europe and in the US and in Asia. But the problem and the challenge is that these are actually more the exceptions than the rules. in many hospitals, we're still far away from this multidisciplinary team. For example, in this retrospective cohort analysis done at the VA of Pittsburgh, they basically show that really a very low percent of patients, roughly between 2 to 10% of patients, receive a treatment for AUD in the context of a patient with liver cirrhosis. They also show that if people receive a treatment, either pharmacological and or behavioral treatment for liver disease, for AUD, for alcohol disorder, the outcomes improve, but only 2 to 10% of patients receive this treatment. So this actually study in hepatology is an example of a paradox that we have in the field, where basically we show that if we treat AUD, we help patients, but actually the number of patients who receive the treatment is very low. It's something below 10%. In this recent paper, for example, from Harvard, they actually had a very nice integrated setup, and they show that the receipt of a medical addiction therapy for AUD was associated with reduced incidence and the progression of ALD. So again, indicating that by not providing a treatment for AUD to patients with AUD and ALD, we are basically preventing patients from accessing a treatment that will help both of the addiction AUD and the liver disease ALD. Of course, it's easier to say than to do. There are many barriers. For example, in this point of view, with Andrea De Martini and Ashwani Singhal, we analyzed the barriers at the level of a patient barriers, at the levels of the clinicians, and the last but not the least, at the level of the system, of the healthcare system. And this is quite challenging, for example, in countries like the United States, where the healthcare system is primarily and heavily dependent on a private health insurance system. There are also other topics which I'm not going to cover today because of time, which, however, are very important as we frame this challenge in the field. For example, the role of sex difference, the comorbidity with obesity, and the comorbidity with HCV. And another challenge I want to mention is that we don't have enough physicians that have been trained in addiction medicine. And this is also a milestone that we have to achieve as we move forward. As an example, in fact, in this recent survey led by AASLD, they show, which is maybe not rock science, but it's so important as a message, that only a minority of doctors in the liver field prescribe a medication for AUD. And the reason is because doctors in the liver field lack knowledge about AUD pharmacotherapy, and also they don't feel they have enough treatment, which is actually a well-taken approach. Not doctors who want to do something they don't feel comfortable to do. So here, the message is not to blame the doctors, but is actually to identify a gap in education and training that we need to fill. And maybe we'll not be able to have every single doctor being able independently to treat AUD, but at least providing them enough training to recognize that there is an alcoholic disorder and refer the patient to the specialist is actually very important. So in the closing, I want also to mention this algorithm, which is also published in this Lancet Gastroenterology Hepatology paper a few months ago, where we basically identify and create an algorithm based on patients with versus patients without apparent liver disease, and how the treatment may actually change based on the severity of AUD, the severity of ALD, but the cornerstone of this algorithm is the importance of building integrated multidisciplinary clinics with hepatology and addiction teams working together. So to summarize this presentation, treatments for AUD in liver settings are not routinely implemented, although there are effective behavioral treatments for AUD, and there are effective both behavior and medication treatments. Additional medications not approved for AUD have been tested, and some of them are promising to treat AUD patients. I mentioned baclofen, gabapentin, and varenicline as examples, but these are on top of naltrexone and acamprosate. And the main challenge and critical needs in the field included the integration of a hepatology and addiction medicine clinical practice and the need for education and training in addiction. Thank you so much. And I will stop sharing my slides.
Thank you very much, Dr. Legigo. Actually, we are running out of the time, but we may take one or two questions. And any questions from the panelists or the speakers, each other? My experience in Japan is so limited about severe alcoholic hepatitis, but I was back in the USC 45 years ago. I was at the Rancho Los Amigos Hospital, USC Liver Unit. And in that time, John Depew, he went back to Canada, published a paper on the steroid treatment on severe alcoholic hepatitis. Today talk, after 45 years, Philip Masurin updated me. But at that time, I realized there was a very rapid problem of the renal failures. So what's the advancement of the treatment of the understanding of the acute renal failures in the case of the severe acute alcoholic hepatitis? Can you make some comment on that? Because
no, I would say that the occurrence of renal failure in this setting is the same probably mechanism that we do know in the setting of any severe liver dysfunction, because as I mentioned, those patients have a higher liver dysfunction, so therefore you have a hepatorenal syndrome, you have a acute liver injury. So I would say the mechanism of liver injury is quite similar to those that have been observed in any acute decomposition of liver disease.
Yeah, those days, people watching only the hepatic failures, but actually patients suffering from acute renal failures, and it's so impressive because the BUN is okay when they came in, but rose up to the 100 in a few days. So I think acute renal failures along with hepatic failures, so impressive. And I don't see those in other diseases. So that's just questions. And about they can stop drinking after even liver transplantations. What are the genetic backgrounds, the genotype, LDH or ADH, anything to do that? Because the ADH deficiency cases, maybe they are having alcohol in the blood and then ling-a-ling-a-ling for some times. So maybe they keep drinking and not suffering the kind of sort of the, when you have a flushes and aldehyde deficiency, but the ADH deficient patients, maybe they keep drinking. Any other genotyping or SNP analysis for these patients keep having the abuse?
No, at least in our, no, I don't think, I don't have the memory of studies testing this in the specific setting of acute hepatitis. I do not think that we have that up to now.
Shivasari, I saw your face. Do you have any questions?
Yes, I have one. First, to tell Felipe that this was the original work done by Professor Omata on alcohol. There was a time when we had his mind for alcohol work when he was in San Francisco with Peter. Coming back to my question, and I want both Lorenzo and Felipe to guide. Whenever we have an obese, morbidly or obese patient who has a severe alcoholic hepatitis, we have a challenge in both calculating the DM as well as in providing the nutrition. We are not able to calculate very well. Sometimes patient is 105 kg or 110 and the calorie goes to 4,000 or so. So the question is, how do you provide nutrition to an obese, morbid obese, severe alcoholic hepatitis? 2, are the severity scores valid in them?
I don't have a specific answer to this question, so I will let maybe Lorenzo to go.
Dr. Lorenzo, would you go?
Yeah, no, it's very challenging. So I guess I would say, well, as we know, when you have those kind of patients with AUD, alcohol disorder, and obesity, in a sense, it's a perfect storm, right? Because then you have a dysmetabolism at the liver level. So you really have two etiologies why they develop a liver disease, right? Both alcohol and obesity. And I think historically, we often think about patients with alcohol disorder as patients with malnutrition, where they are skinny with no fat-free mass. But in reality, in our clinic, when we see patients with AUD, many of them are obese. So I think, I don't know if I answer your question, but I would say one of the goals is actually to treat both. Just like now we try to treat both alcohol and the smoking, when you have a patient with alcohol disorder and obesity, we should actually try to treat both disease in tandem. And the good news is that some of the medications, for example, topiramate, which is quite effective in helping patients with alcohol disorder, topiramate is also quite effective in helping people to lose weight. So in a sense, it's almost like you may help a patient killing two birds with one stone. In my own clinic, we're actually going to launch a semaglutide clinical trial. With semaglutide, of course, we know that it does work for obesity. It is approved for obesity, but we have actually robust data suggesting that the semaglutide and GLP-1 analogs in general may also work for alcohol disorder. So bottom line is, in a sense, we need to treat both. And also the reason why we need to treat both in tandem and early on is because if we don't do, actually, there is now emerging evidence, for example, from Jessica Mellinger and other people, that the people who go through bariatric surgery, they actually end up, they're more likely to develop alcohol problems and to have a liver transplant due to alcohol liver disease, which is, of course, is an alcohol liver disease of a patient who had obesity before.
Just to say that we are saying, just 1 minute, and our paper, there was a paper in gastroenterology in 2016 that aggressive nutritional therapy does not help, which is contrary to what our belief is. But the challenge remains, and there was a Mendenhall paper that if you give 3,000 calories, everyone survives. But the question is, here is a guy who is sick, his bilirubin is 18, 20, and you give him a calorie load of 3,000, will this liver handle 3,000 or 4,000 calories? That is a big question in my mind. I just wanted the opinion on that. We do give aggressive nutrition. We do feed 30 to 35 kilocalories per kilogram, but it's always a question. That's why I asked you.
Yeah, Shib, I think we had wonderful talks and wonderful speakers. That's why we are running out of time. Actually, almost 15 minutes or 20 minutes. So I really appreciate, discussing so hard, and I want to continue, but unfortunately, you got to stop here. So Jay Mo Yang, thank you very much. Wonderful sessions that we are happy to have. So I have to close the session. Do you agree?
Yeah, just I wanted the one question to Professor Sarin. Please show comment about the fecal microbiota transplantation. Professor Sarin, please.
Thank you for raising this. This is routinely done at ILBS. We had challenges in publishing our data for last 2 years, but I hope sometime soon we can. We feel patients both who are steroid eligible as well as ineligible are considered unless they have severe ascites. We give it through nasodiodinal tube, FMT daily for 3 days, and we have very promising results, and it changes the profile. I think wider application of this should be done. And I also know that in Korea, many of the colleagues are working on FMT for alcoholic hepatitis. But yes, it needs more science, more publications, and more attention. Thank you.
So my question is, after withdrawal from steroid treatment, is the next step is liver transplantation, or what about fecal microbiota transplantation?
Well, patients who are ineligible or cannot afford or have no donor, living donor, for liver transplant are considered for FMT, and we have at least 90-day survival in them is better compared to steroids. We feel it is a good modality.
Okay,
It changes the bacterial profile,
Yeah,
and patients do very well. with that.
Right. I think we have to stop here. Thank you very much for the wonderful talks, Dr. Regio and Masrins. Thank you for the sake of the APASL. So we close the session. Thanks. See you soon.
Thanks for having us.
Yes.
Thanks
Thank you,
for having
sir.
us.
Mhm.
Thank you.
you.
Bye-bye.
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 Take care. Bye-bye.
Yeah, Shibusarin. We got to have a single topic meetings tomorrow.
Yes, I'll join you.
Are you coming?
It's too
No.
complicated to
George
reach
Rao is
there.
coming. George Rao is arrived to the Tokyo, Osaka tomorrow.
I will join you, and I wish you my very best for the meeting. Thank you, sir. Thank you.
Thank you. Bye.